My name is Casey Vasta. I'm a palliative care physician assistant with the University of Texas Health Science Center at Houston. I practice palliative care medicine at Memorial Hermann Hospital in the Texas Medical Center. Today we'll be discussing palliative care and hospice. This project is funded by a grant from the Health Resources and Services Administration of the Department of Health and Human Services. The grant was initially funded in 2007 with renewed funding for 5 years beginning in 2010. First, we'll need to review the past and present history of death and dying and understand a major shift in the culture of medicine in the mid-20th century. We'll discuss the concept of total pain and end-of-life symptoms. We'll then define palliative care and understand who can benefit from it. We'll discuss the differences between palliative care and hospice, and lastly we'll review hospice benefits and services. In the early 1900s, life expectancy was around 50 years. Childhood mortality was high, but if you survived childhood, most adults only lived into their 60s. Today we know people are living much longer, and the average life expectancy is now approximately 85 years of age. Again, these are only averages, and 25% will live to be greater than 90 years old, and 10% of patients will see their 96th birthday. Prior to antibiotics, people died quickly and most commonly from infectious diseases. These data show that the top 3 causes of death around 1900 were all of an infectious nature. Medical care at this time was more focused on comfort, as few remedies were available to actually extend life. Those who fell sick were cared for at home and most often died there as well. But with the discovery of antibiotic therapy, namely penicillin in 1928, infectious diseases were rapidly brought under control. Now, the most common causes of death are attributable to illnesses of a more chronic nature, which are often incurable but more prolonged. We can see from the 2010 list, heart disease, cancer, and chronic airway diseases like COPD were the leading causes of death. During the latter half of the 20th century, the age of science and technology had dawned. The nation saw enormous advancements in the field of medicine, with the ability to aggressively fight serious illness and stave off death far better than we could prior to 1950. This caused a significant shift in the values of North American society on many levels. With greater capacity to cure illness and extend life expectancy, we developed a mindset of denying death and placed more value on youth, productivity, and independence, while simultaneously devaluing aging and interdependency. While modern healthcare has learned to cure some illnesses, specifically infectious diseases, today's medicine has mainly achieved the ability to prolong the experience of living with a chronic illness. We frequently attempt and are often successful at prolonging life, and these aggressive interventions have replaced comfort care in the face of life-threatening diseases. This shift in culture has been so complete that death is now seen as the enemy and an off-limits topic. Now we'll take a deeper look at the most common trajectories preceding death. Few people, less than 10%, will experience a sudden event that causes death, such as an accident or major heart attack. Most will have a protracted, life-threatening illness like cancer, with a predictable, steady decline followed by a short terminal phase. Others will have a slow decline, punctuated by periods of crisis, classically in diseases like CHF, COPD, and Alzheimer's disease. Others will have a slow decline punctuated by periods of crisis, as seen classically in diseases like congestive heart failure, COPD, and Alzheimer's dementia. This picture depicts sudden death after an unexpected event. As I said earlier, less than 10% of people will die in this manner. Here we see the steady decline, ultimately leading to death, that is commonly encountered in cancer patients. And lastly, this graph depicts a classic trajectory for patients suffering from chronic debilitating illnesses like COPD, end-stage renal disease, and congestive heart failure. We now know that 90% of individuals will experience a protracted period of decline in their health prior to their death. But before 1990, little focus was placed on how to improve this period in a patient's life. But through the foundational work of Dame Cicely Saunders and the introduction of a palliative care definition in 1990 by the World Health Organization, we now have a field of medicine devoted to alleviating suffering and improving the quality of life in patients with life-threatening illness. It's known as palliative care. What is palliative care? Palliative care is an approach to care that improves the quality of life of patients and their families facing life-threatening illness through the prevention, assessment, and treatment of pain and other physical, psychosocial, and spiritual problems. In simpler terms, palliative care includes a number of interventions that we can do to help our patients and their families cope with the problems caused by a life-threatening or chronic debilitating illness. The World Health Organization has recognized that physical and emotional problems often begin at the time of diagnosis. Thus, their definition of palliative care is not based on the stage of disease or nearness to death, but rather the presence of distressing symptoms. Palliative care offers hope in achieving the best possible quality of life and focuses on alleviating suffering in patients and families during these difficult times. For patients with serious illness, irrespective of prognosis, age, or stage of illness, palliative care offers complex symptom management, emotional and spiritual support, family support, assistance with difficult medical decision-making and discussion of goals of care, support for referring physicians and help with care planning, assistance with coordination of care beyond the hospital, be it at home or through an outpatient palliative care clinic or through transition to hospice care. So this is a good image to help us understand the role palliative care plays in a patient's life, both in the past and now in the current model. Before palliative care, life-prolonging therapies and aggressive interventions were performed until the patient continued to decline to such a point that no further curative interventions could be offered, and the patient was transitioned to hospice care to live out their final days. Today, the model has changed. Life-prolonging care is continued, but the patient receives simultaneous support through palliative care throughout their illness. As the disease progresses, palliative care will begin to play a larger role in the patient and family's life until such a time that the patient and family are transitioned into hospice care. After death, care continues for family members who will receive bereavement support for over 1 year. Palliative care goals are many and range from reduction of both emotional and physical symptoms to improvement of functional status. We coordinate care between various levels and various teams involved in the patient's care and close the loop on transitions between these levels. We help guide informed decision-making. And it's important to note that palliative care patients do not need to give up on curative treatments to still enjoy the benefits of palliative care, and we encourage simultaneous curative and palliative treatments. Most importantly, we strive to improve quality of life. Palliative care is different in that it treats the patient and family as the core unit of care and works to support that unit as a whole. Its strength lies in the interdisciplinary approach to care that focuses on all aspects affecting a patient and their family. And perhaps most importantly, palliative care emphasizes shared decision-making and encourages patients to take an active role in directing their care. Now that we have a better understanding of what palliative care offers, let's see how this matches up to what patients want. We know patients want pain and symptom control, avoidance of prolonging the dying process inappropriately. We know they want to regain a sense of control and relieve the burden of care on family members, as well as strengthen relationships with loved ones. Through palliative care's focus on symptom control and psychosocial support, these goals are met as patients often feel better and even gain more independence and control of their life. Palliative care is appropriate for people of all ages with life-threatening illness, and patients are welcomed at any stage of their disease. People living with congenital injuries, those dependent on life-sustaining treatments, or those who have suffered life-limiting accidents or other forms of trauma are also appropriate. As we said before, palliative care uses a multidisciplinary approach. This slide illustrates the various team members who make up a palliative care team. The clinical team is made up of a physician assistant or nurse practitioner, a nurse, and sometimes a dietitian, a physical therapist, an occupational therapist, and a pharmacist. The psychosocial side is often represented by a social worker, a case manager, a psychologist, and a chaplain. Here we'll take a look at the most common distressing symptoms experienced by patients. Patients often have several, if not all of these symptoms simultaneously as a result of both the disease progression as well as the curative therapy side effects. This list is not exhaustive, but includes constipation, nausea, depression, anorexia, anxiety, spiritual distress, shortness of breath, confusion, insomnia, drowsiness, fatigue, and pain. I've highlighted pain here because, as we'll see on the next slide, it is typically the most common and most feared symptom in patients with life-limiting illness, as well as the most successfully treatable. This study from 1994 shows the most common symptoms experienced at end of life. At the top of the list are pain, difficulty breathing, and nausea or vomiting. Also prominent are depression and loss of appetite. It's important to understand how essential pain control is for patients and the effects of untreated pain. Untreated pain can interfere with daily activities and daily functioning, sleep, appetite, joy, and many others. When pain is well controlled, patients will be able to be more active, sleep better, interact with family and friends, and experience an overall better quality of life. No discussion of pain in palliative care is complete without discussing the concept of total pain. In the 1960s, Dame Cicely Saunders, a social worker who later became a physician and founder of the hospice movement, coined the term total pain to describe the suffering she witnessed in patients with terminal illness. She saw the importance of a multidimensional approach to treating patients with terminal illness, and it was her work that formed the foundation of palliative care. Total pain is comprised of 4 parts: social pain, spiritual pain, psychological pain, and physical pain. Assessing and treating one domain while neglecting the others will often result in continued suffering despite maximum therapies. It is only through attention to all 4 realms that a patient's suffering is best alleviated. Now we will go through some of the many techniques we employ to reduce pain in all 4 categories. In the spiritual pain domain, support by the patient's faith leader and community is essential, as well as prayer and meditation. Social pain is often a result of isolation, financial struggles, and fear of family members being burdened. So through providing financial counseling, coordinating care, and supporting family members, patients' social fears and pain are often alleviated. Legacy work is a special intervention that involves guiding the patient to create some type of lasting work that children or loved ones can continue to cherish in their absence. Examples include writing down or recording family stories, making handprints or molds, and preserving locks of hair. This is especially helpful for patients with young children. Lastly, psychological suffering is extremely common and worsens the experience of physical pain. This entails providing expressive supportive counseling and encouraging journaling or storytelling. Medical treatment of depression and anxiety should also be carried out by the clinical team. For physical pain, There are non-pharmacologic and pharmacologic approaches. Activities like breathing and relaxation, massage, music therapy, guided imagery, meditation, and heat or cold modalities often aid in relief of symptoms. These therapies can be augmented with pharmacologic agents that are highly successful at alleviating a majority of patients' pain symptoms and may be used safely and effectively. Opioids include medications like morphine, non-opioids would be agents like Tylenol, and adjuvants include antidepressants and anticonvulsants to treat nerve-related pain. Many myths exist about pain medications, specifically opioids like morphine. These myths are typically misguided and lead to barriers in successfully treating pain. I'd like to review with you this great list of myths compiled by Joel Potash, a hospice physician. Myth number 1. Morphine is offered to patients only when death is imminent. The stage of illness does not determine which medication is given. Rather, it is the severity of pain that dictates which medicine to use. We start with the mildest medicine, and if that works, we stop there. If it doesn't, we move on to morphine or other opioids when it's appropriate. Some people never need morphine, while others will require it for quite a while. You can live comfortably and functionally on morphine for quite some time. Myth number 2. People who take morphine will become addicted. Hospice patients usually don't have drug-seeking behavior. When their pain is in good control, they don't desire more opioids. Sometimes we can even decrease the dosage. If patients take morphine for a while, their body does become used to it, and it should not be stopped suddenly because side effects could occur. However, hospice patients on morphine would not be considered addicts. Myth number 3. People who take morphine will become so sleepy they can't function. When patients start to take drugs like morphine, they are often drowsy for a few days, but their bodies will quickly build up resistance to the sedating side effects. Most patients whose pain is well controlled on morphine are not bothered by unusual sleepiness and are able to carry out their normal daily activities. Myth number 4. People who take morphine die sooner because morphine causes them to stop breathing. Fortunately, patients quickly adjust to any effect that morphine has on their breathing. We prescribe an initial small dose, gradually increasing it if necessary. In fact, morphine is the drug of choice for treating shortness of breath in people with end-stage heart or lung disease, as it is extremely effective at making their breathing more comfortable. Myth number 5. People should wait until their pain is severe to take morphine so it will be effective when it's really needed. There is no upper dose limit to the use of morphine or other opioids. If pain increases, we can increase the dose. This is true of very few other medications. Using it when it's needed early in the course of a terminal illness does not mean that it won't continue to work later in the disease. As a palliative patient's disease progresses, they will enter a phase of active dying. Palliative care at this part of a patient's journey is called end-of-life care and focuses on aggressive symptom management, family support, and discussions about hospice care. We've mentioned transitioning to hospice care as our palliative patients continue to decline. So what is the difference between palliative care and hospice? Isn't it the same thing? It's actually not. Hospice and palliative care often work closely together, but have several key differences. The goal of hospice is focused solely on comfort rather than curative measures, while patients receiving palliative care can continue to pursue curative therapies. With hospice, the prognosis must be deemed less than 6 months, while there are no time restrictions with palliative care, and patients are encouraged to seek palliative services as early as the initial diagnosis of a life-limiting illness. Hospice can occur at any location where the patient resides, as can palliative care through inpatient, outpatient, and home visit programs. Hospice started in the United States in the 1970s and grew out of a need to help families care for loved ones at home when faced with life-threatening illness. Initially, they were only volunteer organizations, but in 1982, Medicare began offering a hospice benefit if the prognosis was felt to be less than 6 months. With the advent of Medicare coverage, there has been a dramatic increase in the number of hospice organizations, yet still only a fraction of patients die on hospice. In 1983, it was 11%, and in 1995, it had only rose to 17%. Also important to note is the median length of stay is only 20 days, despite the fact that the benefit applies to all individuals with less than 6 months of prognosis. This is largely due in part to late referrals from the patient's healthcare providers. We know that the majority of patients would rather die at home. Specifically, 90% of Americans state they would rather die at home, while the reality is that only 20% will. The majority of hospital deaths could occur at home, where most people want to die, but societal fears and lack of familiarity with the dying process directs the majority of deaths away from the home and into the hospital setting. So what does hospice offer? Hospice provides a physician and home care visits by a hospice nurse. It also provides for home health aides and homemaker services. Spiritual support and social work is included. Medical equipment, supplies, and medications are delivered. Volunteers are available for an additional layer of support, and if needed, physical therapists, occupational therapists, and dietitians can also provide services. Bereavement counseling and support services to family members are offered after the patient has died. Hospice can be provided in 4 different ways. The first is home care. This is the most common level of hospice care. Routine home care includes, but is not limited to, nursing and home health aid services. Patients may receive routine hospice care in their home or wherever home may be, such as in a long-term care facility or an assisted living facility. Continuous home care is provided during periods of crisis in which a patient requires continuous nursing care to achieve palliation and management of acute medical symptoms. This intensive care is provided in the patient's home or wherever home may be. In addition to being visited by team members, the patient will receive up to 24 hours a day care by a licensed nurse and hospice aide. General inpatient care is care for pain control and symptom management that cannot be effectively provided in other settings. It is usually of a short-term nature and can be provided in a hospital, a hospice unit, or a long-term care facility. This is typically the level of care that patients would receive in their final hours to days of life when symptom burden is too high to be cared for at home. Respite care is short-term inpatient care provided to the patient for the purpose of providing a break in caregiving to the patient's caregivers. It is only provided on an occasional basis for a maximum of 5 days every 3 months. Respite care is provided in a hospital, hospice, or long-term care facility. Who is eligible for hospice? Patients with advanced disease with a life expectancy of less than 6 months, people with poor functional status and poor nutritional status, as well as high morbidity, are eligible for hospice care. They or their medical power of attorney must sign consent, and they must have Medicare Part A. I've put a quote here from Dame Cicely Saunders. "You matter to the last moment of your life, and we will do all we can to help you, not only to die peacefully, but also to live until you die." Thank you.